And thanks for coming out early on a Sunday morning to talk a bit about food allergy and eczema. So I'm going to spend the next, well, hopefully I'm going to stay as close to 20 minutes as possible, talking a little bit about some of the misunderstandings and misconceptions around the role of food allergy with atopic dermatitis and trying to help us understand better the role of testing for patients with eczema and questions around possible food allergy. I don't have any relevant disclosures except this is a topic that's really near and dear to me because as a pediatric allergist by training, obviously I see lots of kids with eczema and pretty much universally when they come to see me, their parents are almost hoping that I'm going to tell them that there's a food allergen that if they avoid it, their child's eczema is going to go away. So, this is something that, I spend a lot of time talking with my families about. And I think that it's important that we kind of have an understanding of the current science around this topic. So look, everybody in the room here is very familiar with atopic dermatitis, one of the most common types of eczema. And it's really a very, very common atopic condition. As Mohammed was talking about yesterday, it's often the starting point for what used to be referred to as the allergic march. It typically starts in infancy, certainly the overwhelming majority in the first year of life and a huge majority in early childhood. And that said, it does have a favorable prognosis. I'm often saying to my families that there's a very good chance as they get older that this will go into remission. The problem is that we don't really have any way to make it go into true remission, which means not having eczema without treatment still. We know that for most children who develop eczema, they have an inherited genetic defect in skin barrier function, and that you can even measure an increased transepidermal water loss right at birth, right on their second day of life. We also know that this is a very strong predictor of future atopic conditions like asthma and allergic rhinitis. A large percentage of children with eczema will go on to develop asthma, and there's a bit of a dose response. The patients who have more severe atopic dermatitis are more likely to have the future development of respiratory allergy. So years ago, this is around the time when I was finishing my training, a really important paper came out that showed that over a third of patients with atopic dermatitis in this one cohort had evidence of IgE-mediated food allergy on double-blind placebo-controlled food challenges. The problem was this ended up being, I guess, misinterpreted as to suggesting that for these patients, the food allergy may be causing their eczema, and it meant that people with eczema sort of started on a path of searching for the food that may be causing their eczema. In this paper, while they showed that a significant percentage of these children actually had IgE-mediated food allergy, there was no data to suggest that it was causing their eczema or even contributing to their eczema. The majority of these reactions were immediate identifiable reactions. Most of the patients who had histories consistent with food allergy had discrete symptoms with exposure that were not necessarily related to their eczema as a chronic condition. I'm not going to spend really time talking about the pathophysiology here. It's with the time limits and that it's too in-depth of a topic, but we know that eczema, again, typically starts with a defect in skin barrier function, and then that then is aggravated by exposure to many things. We're now even learning about the different epigenetic contributors like, detergents and other chemicals in the environment that are ubiquitous that may be helping to drive the start of this inflammatory process. So really, I think one of the most important papers that I've read in the last decade or so, I thought was this excellent review article by Diane Campbell out of Australia, really looking at the topic that I'm going to review for you this morning. And really, I think the take-home message of it is that food allergy does not cause eczema, okay? Eczema may cause food allergy. And this is, again, a conversation. I sound like a broken record in my clinic because I'm saying this on a daily basis to patients. We know that it is true that some patients with eczema will flare when they eat certain foods, but that's usually apparent from the clinical history. They usually have obvious immediate symptoms typical of IgE-mediated hypersensitivity when they eat those foods. And frankly, patients with true food allergy are almost always already avoiding the food in question. So when somebody comes in saying, I want to know a food that's contributing or causing or triggering my eczema, the answer is that's not what we're going to find for you. That's not really where the money's at. Atopic dermatitis is not going to be cured by dietary manipulation. Now, we know, again, the opposite very well may be true. If you have severe eczema, and it's very clear that the worse your eczema is in infancy, the higher the rate of food allergy. If you have mild eczema, which is really quite common, your risk for developing food allergy is not dramatically increased. But if you have severe atopic dermatitis or moderate severe atopic dermatitis, that's the single biggest risk factor for subsequently developing egg or peanut allergies specifically. The problem, and again, this is the long conversations I have with patients, is that a majority of patients with atopic dermatitis will demonstrate specific IgE to foods and or environmental allergens. But again, as I'm often saying, that doesn't prove sensitization does not prove clinical hypersensitivity, that these IgE antibodies are necessary but not sufficient for the development of true food allergy. Again, the younger the patient, the more severe their disease, they again may have a food that will trigger eczematous flares, but that's usually apparent from the clinical history. And if you're looking at adults with food allergy, and in my current practice, I see a fair number of them as well, and they also often are seeking a dietary treatment for their eczema, there's very little, if any, role for food allergy with adult atopic dermatitis. And we know, again, that there's a really poor correlation. I mean, all of our jobs in allergy would be so much easier if a positive test simply meant you're allergic and a negative test meant you're not, but it's not that simple. There's a very poor correlation between sensitization to food allergies and then developing either immediate or even delayed eczematous reactions in children with atopic dermatitis. And if you look at the studies where they do oral food challenges, the majority of the reactions are immediate, typical reactions of IgE-mediated hypersensitivity. And again, it's not a previously unidentified allergen in their diet that's aggravating their eczema. And the problem with this is we can cause harm by either over-testing or over-restricting people's diet. First, with the over-testing, it's very hard to unring the bell. If a patient sees a positive test, whether it's a skin or a blood test, in their mind, that food is now a problem for them. And it can be very hard to convince them otherwise, even sometimes after a food challenge that's very obviously successful, because they'll wonder, could it still not be contributing to the underlying eczema, even though the best evidence we have says no. But we also expose our children, especially young children, to risk for nutritional deficiencies. A lot of the most common food allergens are staple foods. And when we restrict them from the diet, we may be causing them a lot of nutritional harm, potentially risk for failure to thrive. But my biggest concern, again, looking from the first do no harm perspective, is that we risk iatrogenic food allergy, which is where a patient was clearly tolerating a food in their diet prior to this testing, told to avoid it based on sensitization alone. And then after some period of strict avoidance, they lose immunologic tolerance and develop immediate clinical hypersensitivity. And in this one paper, what they saw is that a fifth of these patients developed immediate symptoms upon re-exposure, and a third of those were consistent with anaphylaxis. I mean, we're talking about now a potentially life-threatening reaction to a food that had often been previously eaten. And I can't count how many times in my career I've seen a patient who, by history, was clearly tolerant to a food like peanut, told to avoid it based on a test alone. We now see them months or in some cases years later, we do a food challenge, they react. And again, this is iatrogenic food allergy, and I mince no words when I use that phrase with my patients. So again, skin prick test or blood test sensitivity does not equal clinical hyperreactivity. And again, most food challenges detect immediate, not delayed eczematous reactions to the foods. We know that a positive skin prick test in the presence of past well-tolerated exposure has an incredibly low positive predictive value and is very unlikely to reflect true clinical hypersensitivity. And if kids are tolerating a food in their diet without immediate reaction, irrespective of eczema, we should not be excluding that food just based on a positive test without doing some sort of food challenge. And if we are going to empirically try avoiding the food, just to see if it makes a difference. Sometimes with families, you have to go down that path. It needs to be for a very short period of time. Otherwise, we risk losing tolerance and causing a very serious problem. Now, look, we've gotten better data over the years at understanding the utility of some of the test results. Now, you'll look on this list of foods, and there's only 6 things listed here. I mean, if we clump the tree nuts together. And again, we see patients all the time who have panels of testing done for 30, 40, 50 foods, most of which we have no data on how to interpret those test results. But even here, if you look at numbers that, for somebody who's had a concerning history, may be a bit worrisome, we see that even a peanut IgE level of 5, most doctors would say, oh, that's very high. That's, a high class. And now we've got to be very worried about this. If they've had no previous history of reacting, half of those patients are not allergic. Again, the testing is a tool, and the utility of that tool depends heavily on the patient's clinical history. This really important paper looked at this exact issue, and what they did is they just took a bunch of patients referred to a tertiary care allergy clinic in the United States who had a previous food panel test. And the food panels typically in North America are not as extensive as the food panels that I see here, which, contain just an unbelievable, ridiculous number of food allergens. But in this case, for most of these patients, these panels were done for non-immediate reaction reasons. They were done for patients with allergic rhinitis or asthma. They were done for mild atopic dermatitis. They were done for urticaria that was not consistent with an immediate reaction, viral urticaria that goes on for several days, these sorts of things. And what they saw is that in this kind of setting, which is the majority of patients that I see having these kind of tests done, the positive predictive value of these food panels was only 2%. So when I have patients who come to see me and they've had this kind of testing done, I say, did the doctor who did this test tell you that any positive test has a 98% chance of being wrong and only a 2% chance of being right? And of course, they're stunned to hear this. And I always say, would you have wanted a test done that has this poor predictive value? And of course, most of them would say no. But these are expensive and time-consuming processes because now it takes me much longer to go through this. I may have to do a bunch of food challenges in a patient who's now been avoiding foods, and the cost and stress and anxiety to the family and the costs to the healthcare system are really inappropriate and inexcusable. And if you look at the Choosing Wisely campaign that was started in the United States some years ago now, looking at, things that we should be trying to get away from, treating strep throat without doing a culture, and, a lot of these kind of sort of bread and butter things that are really important to practicing good quality medicine and healthcare for our patients. When the allergy and immunology groups got together to figure out what are the things that they should focus on for their part of Choosing Wisely, 2 of the top 10 things that they chose to focus on included not doing inappropriate or unnecessary IgE testing, not doing panel testing for patients for especially food allergy, also not performing unvalidated or erroneous tests like food-specific IgG testing. But, as much as we can rail against those sorts of tests, inappropriate or overly extensive IgE testing is at least as bad, and I could even argue in some cases more harmful because, again, of the risk of iatrogenic food allergy. If a patient inappropriately avoids a food based on an IgG test, I know I can just return it to their diet without any issue. But if they're avoiding a food based on an unnecessary IgE test, I have to fear that they may have lost tolerance and now may be at risk for anaphylaxis, which, of course, is a very concerning development. So to wrap up, again, I think it's really important that we all understand that food allergies do not cause atopic dermatitis. Again, the opposite may well be true. In fact, it's certainly known to be the biggest risk factor for developing food allergy. And as a final take-home message, sensitization does not equate clinical hypersensitivity. So with that, I'll thank you for your attention this morning.